Hi, welcome to our first session on pediatric emergencies. My name is Preethi, and my colleague Shema will also be presenting some conditions on pediatric emergencies. So firstly, we're going to be going through some ATE assessments. So I've basically summarized the ATE approach for your notes. And in terms of the ABCDE approach, it's a structured way to assess an acutely unwell patient. And it's always important to assess it in the order of airway, breathing, circulation, disability, and exposure. At each step, it's really important to look, listen, and intervene if there's a problem. And it's also important to treat issues immediately rather than waiting to complete the full assessment. When you're doing the ATE assessment, it's really important to reassess frequently because once you've done an intervention, you need to reassess to see that if it's made an improvement. And the main aim of the ATE assessment is to stabilize a patient and to improve outcomes even before a definitive diagnosis is made. So throughout the slides, how I've done it, how I've structured it is that I've divided the pediatric emergency condition based on areas of the ATE assessment which has been compromised. So first of all, I'm just going to go through conditions that can affect the airway and breathing. Just bear with us, we've got some technical difficulties.
Hi, Preeti, is it now? Sorry.
Yeah, I'm just going to restart it again because I think people have just joined.
Yeah.
So hi guys, so this is our first session on pediatric emergencies, and The presenters are myself, so my name is Preethi, and Shema.
Hi, everybody.
So first of all, I've just summarized the ATE approach for your notes. So essentially, the ABCDE approach is a structured way to assess an acutely unwell patient. As you might know, A stands for airway, B stands for breathing, C stands for circulation, D stands for disability, and E stands for exposure. When you have an acutely unwell patient, you do the ATE assessment, and for each step, you would want to look at the patient, listen, intervene if a problem is identified. And if there's any sort of underlying issues, you want to treat it immediately rather than waiting to complete the full assessment. And it's really important that you reassess frequently to check the patient's response to treatment. The aim of the ATE assessment is to stabilize the patient and improve outcomes even before there's some sort of definitive diagnosis made. I've essentially divided the pediatric emergency condition based on what areas of the ATE assessment has been compromised. But the notes on the slides are for your revision, so I'm not going to repeat it again, I guess.
Okay, so I'm going to go through airway and breathing conditions that we commonly see in pediatric patients. So to begin with, we have croup, which is quite a common condition that we do see amongst children between ages 6 months to 6 years, and obviously typically occurs due to the parainfluenza virus. Now, kind of the, I guess, buzzwords that they would use for UKMLA MCQ questions is barking cough or a seal-like cough that the child might present with. They also might have inspiratory stridor, which is especially if it's at rest, it's a more severe case of croup. So management for that is just a single dose of oral dexamethasone. And in severe cases, you would want to give nebulized adrenaline and, of course, admit the child if they have moderate to severe croup. Next, we also have something that is quite common amongst our pediatric patients, which is the insertion of foreign bodies. Kids obviously like to put things in their ears, their nose, in their mouth. So a lot of the kind of reasons they go into A&E, we do see foreign bodies. So this is just kind of split for you guys in terms of ear, nose, throat. In terms of ear and nose, and to be fair, throat as well, children like to put batteries in any kind of space, so especially button batteries, and these are considered a medical emergency. So with the nose, if anything goes in, it will have kind of like a foul smell to it, so you can tell that there's a foreign body there. With the throat, you need to obviously try to make sure to take the battery out. However, it is kind of an immediate ENT referral. Same with ears. If they put battery in, you're not meant to actually take it out, but get an ENT referral straight in for that. On the next slide, there's just kind of the presentation you'd expect, depending on where the foreign body is. So with the laryngopharynx, you'd get stridor, you'd get voice change, the child would desaturate or choking. So these are quite common symptoms. Same with respiratory, you'd get the coughing, the choking, and if the foreign body is still there, the child might keep presenting with recurrent infections. In terms of the esophagus, there's kind of sensation in the throat. They'll have dysphagia, and also a lot of saliva pooling. With below the diaphragm, typically they are asymptomatic for this, but they might present with abdominal distension and vomiting. So the next slide is just going through some of the common throat scenarios that we see. So epiglottitis is a medical emergency that we do get in pediatric patients. typically because of Streptococcus pneumoniae. And a key kind of differential here would be think of an unvaccinated child, because if they do present with symptoms of epiglottitis, it typically is either due to Streptococcus, which is the most common cause, or you would want to think if they're not vaccinated, they might have the influenza type B. And this is commonly in the age group of 2 to 7 year olds. Another kind of like UKMLA kind of buzzwords that might appear in the MCQs is that they'll have a continuous stridor, they'll also be drooling, and then they'll also be in a position which is called the tripod position, where they'll be kind of leaning forward to help them with the breathing. Key part of this one is that you don't examine the throat, because there is airway obstruction. So you'd want to secure the airway, and immediately they would require IV antibiotics and ENT referral.
So I'm going to talk about anaphylaxis. This is also a medical emergency. It's actually quite life-threatening. So in terms of anaphylaxis, the key thing to remember is that it's caused by a severe type 1 hypersensitivity reaction. So what that means is that it's caused by an IgE-mediated mast cell degranulation. So what happens here is that these mast cells will then lead to the release of histamines and other sort of inflammatory mediators. And as a result of that, it results in sudden airway compromise, breathing and circulation compromise as well. A key distinguishing feature to remember is that anaphylaxis, if you look at the A to E approach, it involves the ABC components of it. So it compromises that aspect of it. So not just causing skin rashes and mild allergic symptoms. So like you can see on the slides, you can see that typical presentation of a child with anaphylaxis is that they can present with an urticarial rash. They can come with itching, angioedema around the face, the tongue, abdominal pain, shortness of breath, wheezing, swelling of the larynx. And because the larynx is swelled up, it causes obstruction, and they present with a stridal sort of noise of breathing. The child might be tachycardic. They might experience collapse, lightheadedness. So typical management is with a child presenting with anaphylaxis, we know that it's a life-threatening emergency. So the first thing to remember is to do an ATE approach. So once you've done the assessment and you've distinguished that, okay, the child has anaphylaxis, there's 3 main medications to give. So the first one being you would give an intramuscular adrenaline. And if the child doesn't get better, then you want to repeat it after 5 minutes if needed. The second one is antihistamines. So typically oral chlorophenamine or citrazine. And the third one is steroids. So IV hydrocortisone. That's to reduce any sort of swelling. That's the reason why we give that. And typically after you've given those 3 sort of medications, children need observation. And the reason why is there's a risk of something called a biphasic reaction. So what a biphasic reaction is that it's a second reaction after initial improvements to the medications that you've given for the anaphylaxis. So it's really important that you first of all admit the child to a pediatric unit for monitoring. And a key thing to remember for the UKMLA is that the serum mast cell tryptase can support a diagnosis. So it's really important that you measure that within 6 hours of a reaction, anaphylaxis reaction. In terms of discharge planning and following up a child who's had a recent episode of anaphylaxis, it's really important that you educate the parents, because they might be worried when a child's presented with this type of sort of symptoms. So it's important that you give them advice on what sort of allergens to avoid. So whether it's a nut allergy or it could be a dust allergy, it's really important that parents know, have education on this, and they're able to recognize early symptoms so that a immediate response can be given. And specialist allergic referral is really important for diagnosis. And once a child has an anaphylactic reaction, it's really important that you follow them up and you train the parent or the child in terms of using adrenaline injector. So adrenaline injectors are prescribed for all children who have anaphylaxis. So just a key reminder, the key thing to remember is that when someone has an anaphylactic reaction, it's really important that you check the mast cell tryptase within 6 hours. And this is typically a common question that they ask in the UKMLA, so it's really important you remember that. So now we're going to talk about conditions that can compromise the circulation. So sepsis is a really common theme around the UKMLA conditions that they could ask. It's a medical emergency, and the definitions that I've provided on the slides are from the NICE guidelines. So if we think about what sepsis is, essentially it's an infection which makes it could affect child or adults, but we're focusing on pediatric patients here. So it typically makes a child systemically unwell. So it's a severe inflammatory response. It is life-threatening if not treated. So that's why we need a low threshold when we're starting a treatment if we're suspecting sepsis. It's really important that we recognize sepsis early, especially in young children, because the symptoms can be subtle and non-specific, especially in newborns. So if you can see on the slide, I've put, in terms of history, when we're taking a history from a pediatric patient, typically the child might be poor feeding, irritable, they're not their usual cheery self. And in terms of physical examination, you might notice that the child might be feeling febrile, lethargic, tachypnic. You might notice respiratory distress, hypotensive, tachycardic. There might be a bit of bradycardia. So it's really important that we recognize these symptoms really early on. In terms of neonates, sometimes the symptoms might be less specific. So it might be they might have fever, they might be poor feeding and irritable. So those are key signs to just look out for. And it's really important to keep sepsis as a differential because it's a condition that needs to be treated early. If sepsis is not treated, then it can lead to something called a septic shock, which is a dangerous complication of sepsis. And what this is that it's an infection that can affect the heart and circulation. So in septic shock, the blood pressure drops, organs are not getting perfused with oxygen, and lactate levels rise. So as a result, tissues switch to anaerobic metabolism, which is not good. In terms of management for sepsis, how I remember it is the sepsis 6. So you want to give the patient 3 things. So the 3 main things you want to give the patient is oxygen, IV antibiotics, IV fluids. And in terms of taking, this is really important for investigation's sake. So you want to take blood cultures, measure the patient's lactate, and you also want to measure the patient's urine output. So in terms of IV fluids, you want to give IV fluid boluses to improve the blood pressure and perfusion. If fluids doesn't work, you want to escalate to high dependency or ICU. So here what they want to do is give inotropes like noradrenaline. And what noradrenaline can do is that it can stimulate the heart, improve circulation. In terms of antibiotics with a patient with sepsis, you want to start with a broad IV antibiotics as soon as you suspect sepsis, following the sepsis 6 bundle. And you typically want to continue for 5 to 7 days if it's a bacterial infection that we suspect, or if you've already taken a culture and it's confirmed what type of bacteria it is, you might want to narrow down the antibiotics and target that bacteria. Once you identify the source and organism, that, like I said before, you want to adjust antibiotics based on the culture and sensitivity. And typically, a microbiologist is the one who helps guide this. If we think the bacterial infection is unlikely, then and the child is well, and the cultures and CRP is showing up as negative at 48 hours, it's safe to stop the antibiotics. So key thing to remember in sepsis is remember sepsis 6, and remember that in pediatric patients, sometimes it doesn't present as obvious as adults, and the symptoms can be very subtle and non-specific. So when you have a febrile child, or if the parents is concerned, saying that the child is very irritable, poor feeding, then you have to take that concern on board, and it's really important to keep sepsis as one of your differentials. So now we're going to move on to conditions that can compromise disability. So essentially, we're going to be focusing on neurological conditions in pediatrics which can present as an emergency. So the first condition we're going to talk about is a complication that you can get from epilepsy. And this is known as status epilepticus, and it's a medical emergency. So the priority is to essentially stop seizure activity, because if the seizure activity in a child is prolonged, it can lead to irreversible brain damage. And status epilepticus is defined as a seizure that's lasting for greater than 5 minutes, or if you have 2 or more seizures without regaining consciousness. And some of the common causes of status epilepticus is it could be epilepsy related. So if you're missing medication, or if you're having drug withdrawal or altered drug levels. In a child, that's less likely. Neurological conditions you might want to think about: stroke, brain tumor, head injuries, CNS infection. So in a child, you want to think about CNS infections like meningitis, encephalitis, that those things can actually trigger status epilepticus. In terms of metabolic sort of causes which can trigger status epilepticus, you want to think about electrolyte imbalances, hypoglycemia, and substance related, maybe when you think about adolescence, things like overdose and withdrawal, but in a young child, that might not be as relevant. Other causes could be things like hypoxia, shock. If the patient's glucose levels are low, you should give them thiamine or dextrose. However, if the finger stick glucose levels are normal, or if seizure persists, you essentially want to proceed with the first line treatment. So that includes things like benzodiazepine, and an example would be IV lorazepam. So that's the first line. So the key thing to remember from this is that the first line treatment for status epilepticus is IV lorazepam. In terms of what the NICE guideline says, it says that if you look at the second line treatment, levetiracetam, what NICE says is that that particular medication might be quicker to administer because it's got fewer adverse effects compared to the alternatives, if you can see on the second line treatment. Now, if a patient has no response when you give an IV lorazepam within 45 minutes of onset, then the best way to achieve rapid response of seizure activity is you might want to induce some sort of general anesthesia or use phenobarbital. So now I'm going to move on to meningitis. So meningitis is essentially the inflammation of the meninges. And the meninges are a protective layer around the brain and spinal cord. Most cases of meningitis are infective. And when you think about bacterial meningitis, it is an emergency. So bacterial meningitis is the inflammation of the meninges, which is caused by a bacterial infection. The most common cause of bacterial meningitis in children and adults are Neisseria meningitidis or meningococcus and Streptococcus pneumoniae. So those are the key things to remember. In terms of neonates, the most common type to remember is group B strep, because with group B strep, it's typically contracted from birth, because the group B strep bacteria, they live in the mother's vagina. So when children are born, they're more likely to contract group B strep, neonates. If a patient has meningitis but there's no bacteria found, you might want to consider aseptic, which is typically viral meningitis. And typical symptoms of meningitis are, the key symptoms are fever, neck stiffness, vomiting, headaches, photophobia. Patients might have altered consciousness and seizures. If someone has meningococcal septicemia, so this is when the meningococcal bacteria is actually in the bloodstream, they could present with a non-blanching rash. So the key thing to remember is when you're thinking of a non-blanching rash and the patient has symptoms of meningitis, you want to start thinking about meningococcal septicemia. Other causes of bacterial meningitis don't usually cause non-blanching rash. So non-blanching rash, if the patient has symptoms of meningitis, think of meningococcal septicemia. When we're looking at neonates and babies, they can present with non-specific signs and symptoms. So neonates and babies, if they have symptoms of meningitis, it's typically non-specific. So they might have poor feeding, lethargy, hypothermia, and the fontanelle might be a bit bulging. So those are signs that they could present with meningitis in neonates. If we think about investigation, lumbar puncture is the important investigation for all children presenting with symptoms of meningitis. And in terms of management, the key things to remember is that if the child is less than the age of 3 months, you want to give them IV amoxicillin and IV ceftriaxone. If this child is greater than 3 months in terms of age, you want to give them IV ceftriaxone. And to stop swelling, you want to give steroids such as dexamethasone. But in terms of NICE guidelines, NICE actually advises against giving steroids for children under the age of 3 months. So when a child has bacterial meningitis or meningococcal infections, it's really important that public health is informed because these are notifiable diseases. And a key thing to also remember is that if a patient has meningococcal septicemia, the lumbar puncture is actually contraindicated. So if a patient has bacterial meningitis, you can do lumbar puncture. But if the patient has meningococcal septicemia, then lumbar puncture is contraindicated. And the reason for this is that, and the reason why you shouldn't do lumbar puncture is that you should avoid this at all costs, and instead you should be doing blood cultures or PCR. And another key thing to remember in terms of management is if a patient presents with shock, you want to treat any shock with fluids such as colloid. And it's really important to monitor the cerebrum because sometimes whilst you're treating the patients, they can have cerebral edema. So that's really important to monitor. So the next slide, we're going to be focusing on key tests that you can do for children presenting with meningitis. So one of the tests that you can do to prove that a child's positive for meningitis is something known as a Canning sign. So what this involves is the patient's lying on their back, they are flexing their hip and knee to 90 degrees, and they're trying to slowly straighten their knee whilst keeping their hips flexed at 90 degrees. So when they're doing this particular movement, it creates a slight stretch in the meninges. So if a patient has meningitis, they will get a slight spinal pain or resist the movement. So a key way to remember Canning sign is if you look at Canning, the K and the E, you can remember as knee extension being painful. The other sign you could do is something known as a Brodonsky sign. So in Brodonsky sign, it involves lying the patient flat on their back and gently using your hands to lift their head and neck off the bed and flex their chin to their chest. So if the child is positive for meningitis, then that causes the patient to involuntarily flex their hips and knees. Next, we're going to talk about conditions that can affect exposure. So essentially focusing on metabolic conditions, any sort of abdominal conditions. So the first condition that's an emergency is if a child has hypoglycemia. So in a child, hypoglycemia is defined as blood glucose levels below 3.9 millimole per liter. And essentially, the brain needs glucose for energy. So if the blood glucose stays low for too long, it can cause serious problems such as seizures and even brain damage, permanent brain damage. So if a newborn is under 48 hours old, it's common to see transient hypoglycemia. So that's when a newborn presents with hypoglycemia, but it resolves within 40 hours. And the reason why it's common to see newborn under 40 hours present with transient hypoglycemia is because the insulin levels is temporarily high because the body's trying to adjust to the life outside the womb. That's why we call it transitional hypoglycemia. Typically, this resolves by itself. And it's more common, you see it more commonly in preterm babies, babies who are really small, and if a child is really large, and babies who are born to diabetic mothers. So if a child is hypoglycemic and that hypoglycemia is persisting beyond the first 48 hours, um, we need to actually think about other causes. So that can include things like medication or substances or even rare conditions, like it could be hypopituitarism, hyperinsulinism. It could be things like fatty acid oxidation disorders. It could be problems associated with gluconeogenesis. So the key thing to remember here is that if a newborn has hypoglycemia, they've been born within like 48 hours. Think of transient hypoglycemia. So this can be corrected. However, if a child is if their age is more than 48 hours and they have this persistent hypoglycemia, but they don't have any sort of known medication or substance exposure, think about persistent hypoglycemic disorder. And in children, that's typically caused by any sort of metabolic disorders. It could be hyperpituitarism, it could be due to hyperinsulinism. And the management for if a child presents with hypoglycemia is give them IV dextrose immediately. And it's really important that the child is fed as well. So a quick tip for this slide is to consider sepsis in a newborn infant with hypoglycemia, especially if the child is very unstable. So sepsis is a really important differential you need to keep in mind. I've also kind of put two images of the history and presenting symptoms that a child with hypoglycemia can have. And as you can see, if a newborn or infant has hypoglycemia, the typical history is lethargy, irritability, and poor feeding. Whereas in an older child, they will be hungry, they'll be drowsy, they'll be confused. In terms of physical examination, in a newborn child or an infant, typical things you might find when you're doing a physical examination is pallor. The child might be jittery, not their usual self. Seizures. Seizures can be present in some children. It doesn't have to be present in all children presenting with hypoglycemia. In an older child, in terms of physical examination, you will see confusion, diaphoresis, and also weakness. So these things should make you think about hypoglycemia when you think about pediatric patients. So the next condition we're going to be talking about is diabetic ketoacidosis. So this happens when there's not enough insulin, and it's a really serious complication of type 1 diabetes. Now, we usually see this in three main situations. So the first situation is if a child first presents with type 1 diabetes. The second situation is if a child with, if we know that they have type 1 diabetes and they become unwell, usually due to an underlying infection. The third reason is if insulin's been missed or it's not been taken properly. So typical pathophysiology of DKA is that without insulin, glucose can't get into cells. So despite blood glucose being high, what the body thinks is that it's starving. So it will start breaking down fat, and liver will produce ketones, which it needs for energy. So what happens is that the glucose and ketones levels rise. And initially, the bicarbonates will buffer that acid. But over time, when that gets used up, the blood becomes highly acidotic. And that's what we call ketoacidosis, the high ketone levels and the high acidity. So the high glucose levels will overwhelm the kidneys, and that's going to cause glucose to almost spill into the urine. So when glucose goes into urine, it draws water, and that's why patients often get polyuria. And when patients get polyuria, that's going to lead to dehydration and excess thirst. So that's really important to remember. Another key thing to remember is that potassium, because insulin normally pushes potassium into cells. So if we don't have insulin, then potassium is going to stay in the blood. So you're going to get high levels of potassium. Sometimes the levels can even look normal. So the total potassium levels is actually low because it's not getting to the cells, but in the blood it's going to be high. So once insulin treatment starts, what's going to happen is that the potassium is going to shift into the cells really quickly. And that's really dangerous because it can cause dangerous hyperkalemias. And as a result of that, it can cause life-threatening arrhythmias. So key things to remember here is to diagnose DKA, you need all three. So you need the patient to be hyperglycemic, so have high blood glucose levels, ketosis, so the ketones levels need to be high, and the patient needs to be acidotic as well. And in terms of management, we want to do an ATA assessment. And the first line management is IV fluids using 0.9% sodium chloride with added potassium, which is the initial priority. And sometimes with IV fluids, if the patient's dehydrated, that's one of the reasons it could address. And you might want to dilute, you might want to use IV fluids to dilute the glucose and ketones. I also put on the slide another key thing. So there's another condition known as hyperosmolar hyperglycemic state, or HHS. And I've essentially kind of put it so that you can have a look at it and compare the two conditions. So with DKA, like I mentioned before, it's more common in type 1 diabetic, whereas HHS, you see that often in type 2 diabetic. Both conditions, you have hyperosmolarity, you have hyperglycemia, but you only see acidosis in DKA. So that's a key important point to remember about DKA.
So I'm going to talk through a few more pediatric ENT conditions. So to begin with, we're going to discuss epistaxis, so nosebleeds. So these typically occur from the Kieselbach plexus, which is found in the Little's area around the anterior nasal septum. Obviously, this can happen to anybody, and it could be due to a number of things, such as injury and trauma. In kids, we tend to see it due to nose picking, as it's quite an easy area for them to get to. Management for this is quite simple. So obviously first aid measures, have them sit forward, pinch their nose for 10 to 15 minutes. And if that doesn't work, we tend to do nasal cautery with silver nitrate or nasal packing with nasal tampons. If the child is severely unstable, hemodynamically unstable, or has a posterior bleed, then they'll obviously need to be admitted into hospital. With epistaxis, it's really important to consider kind of red flags if the bleeding doesn't stop. So you'd want to consider that they might have a clotting disorder of some sort. I also just want to add that epistaxis doesn't, on the MLA content map, it doesn't come under child health, but it is in ENT under presentations. So next is tonsillitis, also a very common condition that we see a lot in GP practice and also in A&E. Usually does happen due to viral causes, which therefore is quite self-limiting, and you tend to just give kind of safety net advice, give them simple analgesia. If it doesn't get better in 3 days, then they should come back, or if the fever has increased. Typical features, obviously sore throat, fever, painful swallowing, and like in the picture, you can see quite inflamed and large tonsils. Now you can have tonsillitis with or without exudate, so without the white kind of specks there in the tonsils. And always make sure to check for any kind of cervical lymphadenopathy, just for any swelling around the neck area. Some of the complications as well of tonsillitis are otitis media, quinsy, rheumatic fever, which is quite rare but can be a complication of tonsillitis. In terms of determining if someone should have antibiotics or not, so obviously if it's viral, we're not going to give them any antibiotics. However, if we are suspecting it's a bacterial cause, then we'd want to use scoring criteria. So we have the fever pain or the Centaur score. So I believe the UKMLA do like to use the Centaur score a lot. And essentially it's just these points that you guys can see on the screen right now. And if you have a score of more than 4 for the fever pain, or more than 3 for the Centaur score, you'd want to prescribe antibiotics. So first line would be penicillin, and if they have penicillin allergy, you'd want to give them clarithromycin. So next is a complication of tonsillitis, quinsy. So this doesn't come under a UKMLA condition on the content map, but it is something that we all need to be aware of, as it is quite a severe complication that can happen. It typically presents in children who are aged between 2 to 5. And these are also kind of buzzwords that you might see in MCQs, which is the features of it. So trismus, which is a tightening of the jaw, a hot potato voice, which essentially is when they're speaking, it sounds like they have quite a muffled voice. It's like a hot potato is in their mouth. You'll also see uvular deviation away from where the quinsy is. And so I would say those are the kind of three main buzzwords that could come up in a question. So that should direct you towards quinsy. This is an urgent condition, so you'd need urgent ENT referral, IV antibiotics, and they'd need to have incision and drainage of the abscess. So I think that's it for me.
So we've got a couple of questions. We want you to put in the chat if you know the answer to it. So the first question being, a 14-year-old boy presents to emergency department with a headache. On further questioning, he complains that the lights are hurting his eyes, and on examination, the doctor notices a purpuric rash on his chest. He has a respiratory rate of 22 per minute, a heart rate of 40 beats per minute, and a blood pressure of 80 to 60 mmHg. Which of the following tests should not be ordered in this patient? Is it A, blood cultures, B, serum lactate, C, blood glucose, D, lumbar puncture, E, coagulation screen? So if you could put the answers on the chat. Yeah, the answer is D, lumbar puncture. So if we think about meningococcal septicemia, that is a contraindication to lumbar puncture. So if we look at this patient, we can see that they presented with clear signs and symptoms of meningitis, as I've highlighted in red. So whilst his observations also show signs of sepsis, one of the main contraindications to just remember is that if the patient has meningococcal septicemia, don't do lumbar puncture. Now, if we look at the other options, coagulation screen and blood glucose, they're typically normally used in secondary care in patients with suspected meningitis. And like we mentioned before, blood culture, serum lactate, we do that as part of our sepsis 6. So well done. So the second question is, we have a 2-year-old boy who's brought into emergency department with a 3-day history of running nose, fever, and a barking cough. His parents report that the cough worsens at night. On examination, he is struggling to breathe with an inspiratory stridor at rest, mild intercostal retractions, and an oxygen stats of 94% in room air. Which of the following is the most appropriate first-line management? A, immediate intubation in theatre. B, oral antibiotics. C, nebulized adrenaline and oral dexamethasone. D, salbutamol nebulizer. And E, chest physiotherapy. So if you could put the answers on the chat, that would be great. Yep. So the answer is C, nebulized adrenaline and oral dexamethasone. So the reason is, if you look at this question, we've got a child with coryzal symptoms, they've got a barking cough, they've also got inspiratory stridor, and they've got a cough that's worsening at night. So these are symptoms that's associated with croup. So we know that croup is a viral upper airway infection, and we know that it's caused by a subglottic inflammation, and a typical characteristic sign of croup is a barking cough, stridor, and respiratory distress. So in a mild case scenario, just giving the child oral dexamethasone is usually enough. But if in a moderate to severe case where the child has stridor at rest, they even have retractions, you want to give nebulized adrenaline alongside corticosteroids. So antibiotics is not needed in this case unless we suspect a bacterial infection. So that's why that option is not valid. And salbutamol is for lower airway obstruction, not for upper airway obstruction. So in this case, croups are upper airway obstruction. That's why we won't use salbutamol. And in terms of why intubation is not the right answer is because intubation is normally reserved if the patient has respiratory distress. So if everything fails, we're not able to get their airway, there's airway compromise, then the last choice for ventilation would be intubation. But that's not the case in this scenario. And in terms of chest physiotherapy, that's more of a conservative treatment. It doesn't really have an active role when you think about an acute viral croup. So the last question. So we've got a 4-year-old girl with a history of epilepsy. She's been brought to the emergency department by her parents. She's having continuous generalized tonic-clonic seizures for 15 minutes. She is drowsy, pale, and drooling with a respiratory rate of 28 per minute and an oxygen saturation of 92% on room air. Which of the following is the most appropriate first-line management? Is it A, IV phenytoin immediately, B, IV lorazepam or IV buccal midazolam? Is it C, oral carbamazepine? Is it D, admit to PQ and observe without treatment? Or is it E, intramuscular phenobarbital? If you could just put the answer on the chat, that'd be great. Yep, the answer is B, IV lorazepam or IV or buccal midazolam. And the reason why is this particular pediatric patient has status epilepticus. And like I mentioned before, the first line treatment for that is benzodiazepines. So IV lorazepam would be the first line. And second line treatments, you want to think about anti-epileptics like phenytoin, levetiracetam, or phenobarbitons if the seizure continues after you give the patient benzodiazepine. So it's really important that you observe the patient after giving treatment. So in terms of key points for the UKMLA, just remember to recognize if a patient's presenting with seizure, how long is the seizure lasting for? If it's 5 minutes or greater, think about status epilepticus. Just to ensure you know the first line emergency management if a child presents with status epilepticus. So in this case, it would be IV lorazepam, and just know when to escalate to second line therapy. Thank you so much for listening to our session today. If you guys can just scan the QR code and provide us feedback, that would help us with future sessions. And once you fill in the feedback, you should get a certificate and the slides for the session that we presented today. Thank you.